Hi, okay, so I was gonna go ahead and get us started, introduce myself so we can, I guess, get this knocked out. So hello, I am Allison Cowan. I'm an associate professor at Wright State University in the Department of Psychiatry. I'm also a psychiatrist for Ohio's telepsychiatry project for intellectual disability. I'm also curious if you all can type in the chat. There is some audience participation. If not, if we can't do that, I'll just make up the most common answers to these kinds of questions. I forgot to check that. So if somebody could write something in the chat so we could see, and if not, I will just keep on going. All right, so let me first give you my disclosures, which is that I don't have any conflicts of interest, industry or pharmaceutical sponsorship. I do receive grant funding from the Ohio Department of Mental Health and Addiction Services. Thank you very much. I receive grant funding from the Ohio Department of Developmental Disabilities. And as I told you, I'm one of the psychiatrists for Ohio's telepsychiatry project for intellectual disabilities. You will see me drinking my LaCroix. I do not have a LaCroix sponsorship. If you know anybody there, let me know. My other disclosure is that, oh, thank you, Carolyn, for responding there. So my other thing that I often sit in an audience and worry, like, oh my gosh, is this a real case? Is she talking about somebody who's like actually out there? Would they be embarrassed? So all of my cases that I discussed today are de-identified and they're composites. Sometimes I just make them all up. And there's no one single person described. Any, what do they say on TV shows? Any resemblance to real or fictional characters is purely a coincidence. All right, so here's my shameless plug for Ohio's telepsychiatry project for intellectual disability. Look, we serve all of these counties that are included in this map. This might be a little bit outdated, so if you are from one of those counties and your county is not green, orange, or blue, it'll be updated next time, I bet. So we serve 86 of Ohio's 88 counties. We serve over 2,000 patients, and we're a training site for medical students and psychiatry residents. We very strongly believe that people with intellectual disabilities and mental health need good psychiatrists, and that's what we are doing. We are training the next generation of Ohio psychiatrists. I'm very proud of the work we do there. All right, so let's talk over our objectives so that when you fill out your form afterward, you can say if I did these or not. So we're going to describe allied health interventions for patients with co-occurring mental illness and intellectual and developmental disability. We're going to illustrate common non-pharmacological interventions for people with co-occurring mental illness and IDD. We're going to also just talk about practical techniques to meet the needs of people with co-occurring disorders. Good, good that's settled. So so why are we talking about this? Why did I choose this as a topic for us to discuss? So I'm a psychiatrist. The main definition of that very often is a doctor who prescribes medication for mental illness. However, I find a lot of the issues people come to me for are not like solvable with medication. Medication is very important in a lot of mental illness, but very often it's just one wheel of the car. I guess unless it's a unicycle, but I would really rather not be a clown. We need to have all of these services working together to give the best best care for our patients with IDD and mental illness. So let's start. So what I'm going to do is I'm going to go broadly through diagnostic categories and talk about interventions that are non-pharmacologic in nature for each of these specific disorders. My other disclaimer is that a lot of people who have intellectual or developmental disabilities are not included in research. They're very often excluded from scientific studies. So a lot of our research is not useful for people who have IDD, or is not relevant to them, I should say. So I'll do my best to describe where we're talking about research that talks about people who have IDD, and where I'm just hypothesizing. So I will do my very best on that. So let's start with autism spectrum disorders. So I think this is important for us to talk about. So I don't treat autism. I treat disorders that co-occur with autism. So I will treat somebody who has autism and depression. I'll treat the depression. I'll treat somebody who has autism and anxiety. I'll treat the anxiety. There is a bloom of scientific research about this area. So that's what this little graph is. I don't know if you can see my pointer, but so over the last, 10 years, we have this kind of emergence of literature about people who have ASD and mental illness. And I think that's very useful for us to have. And it shows that people have a lot, so people who have autism spectrum disorders are 4 times more likely to have depression and anxiety. And so it's really important for us to know that and to be able to treat them accordingly. So some non-pharmacological interventions for people with ASD and mental illness are cognitive behavioral therapy, mindfulness-based intervention, MBI. These can be overlaid with the things that we already have to support people with autism, like early intervention, social skills groups. I do understand in the autistic community that applied behavioral analysis can be controversial. Just like to get that out there. I try to use people first language, so I'll be using that mostly for this talk, but I also want to recognize that people with autism or autistic people sometimes prefer to have that to have autistic used as the noun. So when I'm working with a patient, I want you to know that I use whatever they prefer. Okay. So what we can do when we're working with somebody who has autism is we can modify the skills we already have. So we can modify treatments. So for psychotherapy, we would use structure in an increased way. We could use increased visual materials. Like, so somebody that you would normally just like describe something in words, somebody with autism, you might want to have like a visual chart or have like a diagram kind of explaining what you're talking about. You want to make sure to use concrete examples and language. You might need to use more psychoeducation on emotions and anxiety, just identifying those things. And you might need to have flexible length of sessions suited to the patient's needs. So if a person can only tolerate like 20 minutes of a session, great, have a 20-minute session. So sometimes people can only tolerate like a reduced amount of time. So go ahead and just make those adjustments. Our other treatments that I find very often get overlooked when I'm working with somebody who has autism is the use of occupational therapy. There are really, really great occupational therapists out there that specialize in sensory evaluations for kids and adults with autism that very often we just like forget. By the time somebody gets to me, sometimes we haven't like reevaluated those needs recently. So that's a very, very useful resource. Speech and language pathology can be very, very helpful if we're struggling with communication needs, if somebody's upset, angry for not being understood, or we're having so many communication issues, that speech and language pathologist can be so helpful in just kind of helping us navigate communication barriers. I also find sensory accommodations to be very useful. Hopefully this is all not news to you, but I think it's so important that I just remind everybody. So this could be as simple as like dimming the lights in your office when somebody comes in. Sometimes the lights are too bright, or making sure the space is quiet, or making sure that you have music going to kind of drown out the competing sounds. And then when you're working with somebody who has autism, please always take care to evaluate for risk of abuse or neglect. A lot of times the first kind of clue we have is that something is wrong is somebody will start having behavioral outbursts. So it's always good to be watchful for that. And like I said before, that we want to make sure to treat co-occurring disorders. Please don't fall into the trap of, oh, that's just their autism. So if somebody meets criteria for depression, anxiety, those are important things to treat. All right, so let's go through our first case. Our first case is Mr. A. He's in his mid-20s. He's been brought to his outpatient psychiatrist, me, for self-injury. His self-injury is hitting both ears with both of his fists, so like that. What else do we want to know? Okay, so if you could type it into the chat, or I can just, oh no. Okay, let's see. So I'm gonna say that somebody out there is gonna say, oh, you know, like how does he feel? Does he have an ear infection? Does he have a headache? How is he doing health-wise? Good, I'm so glad you came up with that answer. Yeah, no ear infections. Oh, good, I'm so glad that you asked about his constipation. No, he's been having regular bowel movements. We've kind of tried ibuprofen and acetaminophen, and that didn't really seem to help. So what else is going on here? Oh, that's a great question. When did it happen? So when we go ahead and ask Mr. A and his team, is it when that one housemate really nags at him? If that's the case, we would want to address this not with medication, but with adjusting environment. So if a disrupted routine, if a noisy surroundings, or this says annoying, which I find is mean, but like I think we've all probably had annoying housemates. But yeah, so when that happens, like what can we do to adjust the situation and not prescribe a medication? Good, I'm glad we all found the right answer. Oh, look here, okay. Is it somebody else wanted to know, is this new? What was going on before? So we're asking for antecedents. I think there's a little lag in the chat. So any prior history of this behavior, these are all great questions that we would want to know the answers to before we go ahead and start a medication. If we even needed to, we might be able to avoid this by like, as people get off the van, maybe one housemate goes this way and one housemate goes that way, because that's a lot of togetherness sometimes. Okay. Let's see, I'm moving this chat around. Okay, our next one. So let's also talk about neurocognitive disorders. So this is the psychiatric term for essentially dementia, is what I'll be talking about today. So with somebody who has intellectual and developmental disabilities and dementia, what we want to do is our aim is to improve cognition, enhance well-being, and improve the quality of life. We want to reinforce schedules. We want to look at behavioral activation, so keeping people busy and engaged. Sometimes if somebody lives in a congregate setting, a psychoeducational group for housemates to kind of explain like, you know, they're not doing it on purpose. They're not doing this to be mean to you. They're struggling with memory problems, to kind of explain what's going on. The most important thing that I want to talk about is dementia-informed environment. That's our next slide. So we'll get to that one. But we'll also want to see if there's anything available like music-oriented therapy groups, which sound wonderful. If anybody knows where those are, please let me know. I would love to send my patients there. There's something called life story work, where you kind of work with somebody about like their life story, those meaningful times in their life, to kind of create or maintain that cohesive sense of self. And then to de-prescribe. So take a look at those medications which could be impacting cognitive function. So benzodiazepines, so that's like Ativan, lorazepam, Klonopin, clonazepam, those kinds of medications. Yeah, and so Janet in the chat says, keep daily interactions reality-based to help them focus on time, place. Yes, so just remind, absolutely. But yeah, so taking a look at somebody's medication list and seeing what we can take off of there safely to help preserve cognitive function. So I got so excited when I learned about dementia-informed environment. Really sorry if you all are total pros out there at this. I just want to share about what a dementia-informed environment is. If you've worked in a nursing home, you know what this is because they are usually pretty good at using visual cues to remind people kind of where they're supposed to be. So a dementia-informed environment will take care to not have people overstimulated by too many signs and notices. One of my favorite fried chicken places in a gas station has 30 signs up on the case about the rules that there are when you order a chicken. So we don't want that kind of overwhelming amount of instructions. We want things to be simple. We want handrails to be visible. So sometimes handrails and toilet seats, if they're the same color, can be really confusing. So then if somebody's having toileting issues or incontinence, take a look at that to see take a look at the, toilet seats to see if it's clear where you actually should be going, if there are good visual cues there. And then shouters or dark stripes in the flooring can be seen or perceived as a change in level, like a step down or a step up. And so people can get kind of caught trying to step over them. And then very often people can think shiny floors are wet and slippery. A few of my patients won't go out when it's raining because it looks icy. It looks wet and slippery. So those are just important things to pay attention to. Oh, Carolyn, thank you for saying in the Cincinnati area there is music therapy care. Excellent. That is wonderful. Thank you so much. All right, so more about this dementia-informed environment. So cognitive stimulation with meaningful activities. And I think somebody in the chat had said that earlier, keep them engaged, keep them reality-based. We want familiar things there, just to remind them, to jog their memory, photographs, memory boxes. But then also instead of industrial cups and dishes and silverware, also just regular, traditional crockery and cutlery. I think this is a British study. But those can be very helpful instead of kind of more institutional items. Wayfinding is really important. So signage with text and pictures. So maybe their name on their door with a picture of them. Accent colors, and then identification of beds and bedrooms and social spaces, labeling sometimes if a person has the ability to read. And then we like things to be visible. Hopefully this all should be very common sense, but also it's so common sense that very often we forget to ask about it, or we forget to take this into account. So we like large clocks, natural light, and artwork that can reflect the seasons, and then access to outside spaces if safe. All right, so our next case, Miss B was brought to the psychiatrist but couldn't make it into the office. So she was stuck out in the car, couldn't make it over the vast entryway of the lobby. It was shiny. She had been noted to be crying more and staring into space while she was lying in bed, and then she wasn't interested in her favorite TV show. What would you want to know more? You would want to know how long has this been going on? Is she sick? Is there anything else going on with her? So that's the thing with dementia, is that we want to make sure something else isn't going on first. We want to make sure she's not sick. We want to make sure she's not constipated. Right, so is she depressed? Has she had any recent losses? Good, that's a good question. So her family doctor had started her on Zoloft or sertraline to no effect, and then cross-tapered mirtazapine, nothing. So we've kind of tried to treat for depression, and that didn't really seem to be it. And then if this was determined to be dementia, how could we reasonably treat her if we're pretty sure it's not something else? Oh yeah, so somebody else wants to rule out a UTI. Yeah, so people can get confused when they have UTIs and just kind of listlessly lay in bed. They can sometimes see things that aren't there. Absolutely. Yeah, so we would just want a better picture of her, how she was doing before, if this was a slow decline, if this was something rapid. Those are all very important things for us to determine. Okay, but yeah, so we would also want to focus on having light open spaces, reminders of the season, reminders of time, like a good schedule is a really helpful thing for people who are dealing with dementia and intellectual and developmental disabilities. All right, so next is psychotic disorders. I think in a couple weeks I'll have a whole talk just on helping people with psychotic disorders who have intellectual and developmental disabilities, but for now we're only going to focus on the non-pharmacological treatment. The caveat being that the standard of care for psychotic disorders is antipsychotic medication. So I think that's on every slide going forward. So just remember, even though I'm talking about all of these other things that we can do, it's really just best to have somebody on an antipsychotic if they have schizophrenia, schizoaffective disorder, and sometimes bipolar disorder. So let's talk about hallucinations. So hallucinations is typically hearing mostly and seeing things that aren't there. Remember that they can seem real to the person. So this is like, it seems real when somebody starts to get better or as they're starting to get sick with one of these illnesses, they can kind of say, well, I know they're not real. They just bother me. I could ignore them. But when somebody's like pretty impaired with a psychotic disorder, they seem very real to the person. My next point is that I think this is something that comes up most commonly in my office, is that people who have intellectual and developmental disability have self-talk. So that's the kind of like mumbling to yourself, kind of talking to yourself, maybe under your breath, maybe sometimes just out loud. I maintain that most all of us have self-talk. It's just that we can usually keep it under wraps, but you might think back to the last stressful day you had, where maybe you left your coffee at home, you lost your keys, and then you couldn't find your cell phone, and you were saying like, oh my gosh, I know it's here somewhere. So sometimes when we're alone, we'll have that self-talk ourselves. The other thing, my other example for this, that if you know me, you've already heard me say, sorry in advance. This is also like when you're in the shower after, like, 3 days after somebody said something kind of mean to you, and you think of the best comeback, and you're like, yeah, in your face. Like when you have like that kind of moment where you like are like, yeah, I should have said that. So that's kind of my idea of self-talk. That's pretty normal. It's not an indication that you have a mental illness. So the difference between hallucinations and self-talk is that hallucinations is active hearing or seeing things that aren't there. Self-talk is sometimes just like replaying a conversation back that you heard earlier. It's also saying that great comeback that you remembered later. It's also just kind of working through feelings like, oh, they shouldn't have said that to me. I can't believe, I was waiting in that line for so long. Like those kinds of things are self-talk. Hallucinations is like, I hear somebody talking to me. Okay, so hopefully that helped. Okay, so what we do, oh yes, here's my antipsychotics are the treatment for psychotic disorders. Here are some things that we can do. So these are adapted, I have adapted these from people without intellectual and developmental disabilities for use in people who have intellectual disabilities and psychotic disorders. So music and headphones can be very helpful, especially if you have a lot of auditory hallucinations. Putting on the music or listening to headphones can be really helpful. And then just TV, movies, video games, like anything to kind of compete with the other noise White noise machine at night can help you get better rest if you're, it can also be helpful for intrusive thoughts. So that white noise machine at night can kind of drown out the competing noises. And then when you're working with somebody who has IDD and psychotic disorders, just we don't argue because it's not really helpful, but we can use gentle leading questions as a reminder that the voices aren't real. So sometimes you can say, hey, you know, like, we've talked about this. Do you really think that there's like somebody saying this to you, or like, is that true what that person is saying to you? That's really mean. So kind of having somebody start to look at the truthfulness of what the voices are saying can be helpful. And then there is a formalized psychotherapy for hallucinations. So it's cognitive behavioral therapy for psychosis. I'm pretty sure they're like teaching that at the Beck Institute. It's really interesting. I haven't done the training, but I saw like a little snippet of it, which is really, it's like really cool and hopeful. All right, so two of the big things in psychotic disorders are the hallucinations, and then this next one is the delusions. So those are fixed false beliefs. So that's like somebody believes something that isn't true. So if somebody believes something that is true, that's not a delusion. So if somebody says, like all my direct care professionals are talking about me when I'm not there, that might actually be true. They might have had a team meeting to discuss like how to handle things. So that might not necessarily be a delusion. But if we have, I don't know, space aliens spy on my bowel movements, less likely to be true. So that is much more likely to qualify as a fixed false belief. And again, we talk with people, we don't argue with them. It's just not helpful. And then everybody ends up mad if we argue. So we try to have a collaborative relationship. Yes, and antipsychotics are the treatment for psychotic disorders. Okay, so the other part of psychotic disorders are the negative symptoms. And very often these negative symptoms can be mistaken for the side effects of the medication. So side effects of medication are also on this list. It can make people feel slowed down. It can make them kind of, I think the popular term in culture is like to be like a zombie. So sometimes those can be the side effects of the medications, but a lot of people don't know that that can actually be a symptom of the illness. So the negative symptoms of schizophrenia are blunting of affect, meaning like how your face makes emotions, like conveys emotions to other people. Poverty of speech and thought. Oh, typo. Poverty of speech and though. That just means not talking a lot and maybe not even thinking a lot. Apathy means like not caring very much. Anhedonia means not caring about the things that you used to like. So not finding pleasure in doing enjoyable things or things that used to be enjoyable for you. Lack of motivation, and then just lack of social interest. And then kind of not being very reactive to social input. So these can be some really heartbreaking symptoms of schizophrenia. So what we would want to do kind of overall for people who have intellectual disability and psychotic disorders, and again, this literature is not in people who have intellectual and developmental disabilities. This is translated from people without IDD. So cognitive behavioral therapy, motivational interviewing, usually that focuses on looking at like, hey, how can we make it easier to take your medicine? What's getting in the way of remembering your appointments? How can we make this? Tell me the bad parts of your medication, so we can kind of work through that. Supportive psychotherapy, case management is so important. Thank you to all the case managers out there. You were really, really, really wonderful. Vocational rehab for folks who have IDD and psychotic disorders is really important. And sometimes just letting the vocational rehab staff know what's going on. Oh, they're having a bad time. I don't say that as the psychiatrist. I would let the team pass that along if they feel like it's, if my patient feels like it's something that would make it easier for them to go to vocational rehab. And then assertive community treatment is something that community mental health centers have, where the psychiatrist or the nurse practitioner and the treating team comes out to your home to help you take your, usually like your monthly injection or to get your clozapine lab draws. So that's a really important resource that we have. Okay. So other things that I always like us to remember is for psychotic disorders is family psychoeducation is very important. So we need to let the family know with my patients, with the patient's consent, we need to let the family know what we're looking at, what we're looking for, if we're monitoring for relapse, what everybody needs to be like watching out for. Supported living can be very helpful, social skills groups, habilitation activities, and then we would work as able, like encourage work as a person can do. And then just remember that psychotic disorders can have significant impact on cognitive function, like meaning IQ sometimes. And that's very important, that a person after having a schizophrenia diagnosis might not have the same abilities that they had before. And that can be really difficult, especially for families who, who have usually had an IDD diagnosis, and they've come to terms with that. And this is a new diagnosis, usually in somebody's teens, 20s, or 30s, after they had already adjusted to a child or family member with IDD. This additional condition starts. Scheduling is can be really helpful. And then we want to encourage routine health care, given the risks of premature mortality, both with IDD and with serious persisting mental illness. It's really important to get that health care for folks. Yes, since antipsychotics. Okay, so our case here. So Miss C reports that the voices are better and that the people aren't bothering her as much by taking control of her body like they were before. When I ask, like, she says, oh, I'm fine, but her family's concerned and she doesn't do the things that she likes anymore, like watching her favorite reality TV show. What would you want to know about her? Yeah, so is there a social pressure to minimize symptoms? So do we have somebody who's worried about like worrying other people? Somebody else wants to know, who are these people? Tell me more about these people. Agreed, those are all great questions. All right, so, oh yeah, somebody in the chat says, when was the last time they talked to you? So we want to hear more about these people. So any medication changes? Has medication been adjusted recently? Any other medical problems? Have we made sure something else isn't going on? And then social, what else is going on in Ms. C's life? And then what would you recommend? How would you reach this person? I also love in the chat, yes, absolutely, I agree. We got to make sure that there aren't medical things going on. It's missed so often, especially if we have a communication barrier. Those medical issues, it's harder to catch them, and it's harder to, sometimes it's harder to get treatment. Yeah, so we would want to know, somebody in the chat says, is she engaging in any other new activities that are taking place of watching TV? So best case scenario, she's not into a reality show because she started playing on the Special Olympics softball team. That would be great. That would be wonderful. If she is just uninterested in everything, we would want, and she has a psychotic disorder, that the people is a, like, that's a delusion about people monitoring her. we would want to do something like a day hab or a drop-in center. That would be great. We also have opportunities for Ohioans with disabilities. So that's some of my patients get job coaching from there. It's a really great resource for folks. So yeah, we would just want, so if Ms. C does turn out to not have a medical illness, to not be doing something better than watching TV, to not be depressed, and to have a psychotic disorder, we would want to really engage socially and to maintain as much function as we could. Okay, so our next one is bipolar disorder. Again, with bipolar disorder, we want to more so rely on medications, and we can do other things to augment the effectiveness, to help out the medications. So we want to minimize sleep disruptions. We want to really talk about psychoeducation. So like, this is what bipolar disorder is. These are the things that can trigger a new episode. Family psychoeducation is really important too. So letting the family know, it's really important to have like a regular routine, to have things as stable as we can get them. There's CBT for people who have bipolar disorder. Group therapy can be helpful. There's a specialized psychotherapy for bipolar disorder called interpersonal and social rhythm therapy, and what that looks at is managing a person's life so as to prevent relapse as best as possible. And then case management is just really important. Like, we need all the support we can get. But yeah, medications are important here too. Oh, and I'm sorry, so this literature looks at people without IDD. This is neurotypical, or I guess general population research. Okay, so Mr. D, here's our case. Okay, get your typing fingers ready. So Mr. D went to camp for the first time when he was about 25. He was reported to be up all night. While he was there, he was talking a mile a minute, trying to pass out communion, which was hot dog buns in the cafeteria. So I didn't go over the symptoms of bipolar disorder. But this seems to fit. This seems to fit with that. Okay, so what should we tell him? I guess, what would we want to know? Would we say, Mr. D? Yeah. So somebody asked, has he been getting adequate sleep? No, he was up all night while he was at camp, and he just came home and he was just still up all night, still talking a mile a minute. So no, not getting enough sleep. So somebody else asked, is this typical for him? So no, he had been doing fine up until this one event. Yeah, so somebody else says, was he getting sleep before camp? Like, yeah, he was doing okay. He had a pretty good routine. There'd be a night here or there where he wouldn't sleep, but then all of a sudden he was just not sleeping. Okay, so if this does turn out to be bipolar disorder, decreased need for sleep, increased talkativeness, increased fidgetiness, increased goal-directed activities, and then kind of trying to pass out a non-communion thing in the cafeteria is, I would say, a little bit troublesome for maybe like a religious delusion. Now, if this is socially acceptable in his community, that's fine. But usually churches don't give out hot dog buns for communion. You never know. So yeah, I would want to know more about this. Yeah, and somebody else wants to know, did he miss taking any medication? I would also be curious about, did he start on any steroids for like a breathing problem? Did he get some prednisone and this is a reaction to that? Did he get started on a new seizure medication? So those are all really important things to note too. But when we look at what supports we can provide somebody with bipolar disorder, we can look at his sleep schedule, which I think everybody in the chat is very concerned about, like getting him back on routine, talking with his family about like what are the things that we can do to support him. And then, yes, somebody said about we could use motivational interviewing for medication adherence to continue to support. All right, so depression is our next little topic. It's not a little topic. I shouldn't say that. I shouldn't diminish the impact of depression on America as a whole, which is pretty debilitating. So we have good non-pharmacological treatments for depression. We have CBT, we have supportive therapy, we have psychodynamic psychotherapy, acceptance and commitment therapy, and narrative therapy. All of these have at least case reports in people who have intellectual and developmental disabilities and depression. So if you were a therapist, never mind. If you're a therapist, you already know this, but for the other people in the audience, there are treatments that have been adapted for use to treat people who have IDD and depression. It's really interesting to see how those are adapted. So some of the clinical pearls are that I would like to see in somebody who has depression and IDD are behavioral activation. So still doing those things that people like. So getting out, going out to eat, even though we're all trying to lose weight. So like getting out, going out to eat, maybe going to the movies, going to the park, going for a walk, any outdoor time. Can you spend time with pets? There's a really great vocational rehab center. I think it's in Lima, called Friends of Leroy Brown, and they like work with the dogs and they get to take care of the animals. So anything like that that we can have access to, or that we can get somebody set up with, is just a really good way to get them like re-engaged in life. Environmental factors are really important. We can't fix with medicine somebody's in a bad situation. So as well as we can impact those things, those are important too. So sleep, all very important. We would want to minimize alcohol and illicit drugs. We would want to look at any medical causes. And then if we could support any family connections. Sometimes it's really hard to keep those like family connections going. And so if we could facilitate that in any way. All right, so here's our case. Miss E's mother passed away last year, and Miss E suddenly had to move into a group home. She hasn't enjoyed the things that she normally does, like watching movies. What are your first steps to help Miss E? Yeah, so somebody says assessment of overall adjustment to transition, grief counseling, yes. So absolutely. Yeah, so somebody says, how has she been supported in her grief? Does she understand what happened? Yes, absolutely. So grief and loss, I know it says depression on the top of this case, but it's not necessarily. So this first is to assess grief and loss. Absolutely. We also want to make sure that, so our first steps are making sure somebody has a safe environment, that they are able to stay connected with family and friends. Very often that one point of contact has facilitated all of the other contacts with all of the other family members. So do we have a way to stay connected? Acknowledge grief and loss, and then we might consider just a general wellness checkup, a referral for therapy. But yeah, mostly we want to support Miss E in her grief. There's some literature, I don't know, about 20 years ago that looked at people who have IDD, and a lot of the common thought, even just as recent as 20 years ago, was that people who have IDD don't experience grief, which isn't true. But as recent as that, it was generally not recognized. Yeah, so somebody says trauma-informed care, identify current support systems. What was the dynamic of the relationship? How much of Miss E's life was connected to her mother? And then remember that oh, this is really sweet. Remember that we all want choices, and she had to move and it wasn't her choice. She could be angry and frightened as well as depressed. Absolutely agree. Okay, so anxiety. A lot of these treatments are the same as treatments for depression. So we have psychotherapy, so CBT, supportive, psychodynamic, and acceptance and commitment therapy. I'm pretty sure these are, our research here is in people who have intellectual developmental disabilities, at least a case study or case report. Okay, so my clinical pearls here is that there is a thing as the question reassurance cycle. So very often, a person is anxious and they'll ask you the same question over and over again. And it's that kind of seeking connection and then kind of wanting the reassurance. But then sometimes that can kind of snowball into somebody needing a lot of reassurance or kind of constant reassurance. So kindly and with compassion, if we could disrupt the question reassurance cycle. So if you've answered a question 100 times already, you can gently say, oh gosh, what are we having for dinner? I think did we just talk about this? So if you're able to do it in a kind way, just kind of step out of that cycle. Routine and structure can be very helpful. And to also remember that worry or questions can also just be in like a kind of maybe a clunky way to start a conversation. So I would like to talk to you. I don't have anything to talk to you about, so I'll ask you what's like, oh, that might be my next slide. But I might just ask you, you know, what time are you coming to work? 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 So that might not necessarily be worry. That might just be like, I want to talk to you because I think you're cool. Other sources of anxiety is like too much news. Like, I mean, like on the television, like too much news on the television, and then not enough news there. I mean, like keeping secrets. People know, like people know if we have a secret, and then sleep is really important. Okay, so here's our next case. Mr. F's new home manager brings him in to a psychiatric intake for being forgetful. She worries that he just can't seem to remember what they talked about. So he'll say, what's for dinner? And she'll say spaghetti. And he'll say, what's for dinner? And she'll say spaghetti. So it's just this kind of cycle. So yeah, we would want to know if he has a hearing impairment. Is she answering him and he doesn't hear? We would want to know if there's some other kind of medical thing going on. But a lot of times this is just somebody who just wants to talk, or they can be nervous too. I think somebody here says, doesn't this happen with everyone? In my house, yes, very much this happens with everyone. What are we having for dinner? What are we having for dinner? What are we having for dinner? And then somebody says, do you have any recommendations if gently trying to move away from the repetitive questions doesn't work? In my experience, what I do is I say, objection, Your Honor. So if I've answered a question 5 times, I will say, objection, Your Honor, asked and answered, which is like court TV talk for like, we've discussed this, I'm not going to be doing this again. And usually if I'm not mad, it's, you know, it's a pretty easy thing. I do have to be more careful. If I'm irritable, I want to be careful not to hurt anybody's feelings. Will all the staff? Okay, Christy, if you want, I'm sorry, I don't understand. So doesn't this happen? Oh, you mean, does this only happen with this one staff? Yes, finally, I got it. Thank you. Yeah. Yes, so does Mr. F really like this new home manager? Does he just want to like talk to her about something? Yeah, absolutely. And then somebody else wants to know, is there any possible history of TBI? Is he under stress? Is he getting proper sleep? Good, absolutely. Oh, and somebody else, I don't know if I said this one, maybe ask what their favorite dinner is. So if somebody's asking the same question again, maybe like just start the conversation. Well, hey, we're having spaghetti tonight, but what's your favorite dinner? Is it tacos? Tell me about the tacos. Tell me more. Okay. Should we start a medication? If you have looked at the topic of this, This talk, no. No, we're not starting a medication today. Okay, trauma-related disorders. I just like this picture because sometimes a match can represent something much bigger. I'm trying to see, I wanted to do a content warning for anybody. So in a couple slides, I will have a clown. If you were afraid of clowns, go ahead and turn your face away. It's not yet though. So treatment for PTSD in folks who have IDD is very important. Our folks who have IDD and trauma, it's like a huge percentage of folks. So please just be aware. So treatments of choice are trauma-focused CBT, child-parent psychotherapy, EMDR, I think somebody mentioned that in the chat, psychodynamic psychotherapy, and then supportive psychotherapy, exposure therapy have been used to treat folks who have IDD and PTSD. Oh gosh, okay, this is my reminder. If you are scared of clowns, close your eyes. So, so for those of you who are scared of clowns, you recognize that this red balloon very much reminds you of something else. So this is kind of like just a reminder for us to be aware that sometimes the thing can be a red balloon. Okay, and then close your eyes if you are scared of clowns. The next one is scary. And then sometimes that red balloon can represent like this terrifying sewer clown that's really frightening. Okay, so if you can now open your eyes if you were scared of clowns. I have moved on. So I feel like we have to talk about trauma-informed care. I'm sure all of you are very familiar. If you are not, here is what it is. And then I also really want to talk about deprescribing. That's really important. Very often folks with trauma get a lot of medications prescribed to them. And it's my job as a psychiatrist to make sure people aren't on too much medicine and to have them on the least amount of medication possible. Okay, so OCD is our next topic. I want to talk about OCD, hoarding, and skin picking disorder. These are the most common ones that I see. Sometimes trichotillomania, which is like the hair pulling. So OCD treatment is CBT with exposure and response prevention, acceptance and commitment therapy, supportive psychotherapy. And then just our clinical pearls here is to resist doing the compulsion. So maybe first just tracking it and then trying not to do it for a little longer. So like just kind of putting it off and then extending that time. Yes, differentiating between autism spectrum disorder, OCD, and OCPD is very difficult. Calm patience is helpful, and then arguing or forbidding is not helpful. And it's please also get help from your psychiatrist to treat OCD. We have some medications that that can be helpful. It's just a really difficult illness to treat. Okay, so if somebody has hoarding disorder, just remember and to keep that in context if they have institutional experience. This is our beautiful Dayton State Hospital over here that this is a picture of. So if we're able to do CBT and home visits, motivational interviewing can be helpful, and lack of insight can be a major contributing factor. And you can't just throw this stuff away, it just comes back. This data is not from, this is just my personal experience and not specific research for people in IDD. And then skin picking can be, we would want to use the same types of treatments. All of these are kind of related disorders, but keeping wounds well moisturized, monitor for infection and spread of infection, and keep the nails short and clean. And remember that this can be a signal anxiety, that it can be an indicator of how kind of overall stressed somebody is. Okay, so insomnia, CBT-I, so CBT for insomnia, can be helpful. Sleep hygiene is the thing I spend most of my time. Oh, yeah, sorry, somebody asked, what is OCPD? Sorry for all my acronyms. OCD is obsessive compulsive personality disorder. There's a personality disorder that is described as kind of obsessive and compulsive. This is like the tidy person that likes things to be tidy all the time, but so much so that it gets in the way of their life and kind of interpersonal connections. It's a really interesting disorder. I wish I could do a whole talk on that. I actually do I think I have a personality disorders talk a little bit down the line, so maybe you would like to tune in for that. So CBT-I is CBT for insomnia, but most of the time we just want to look at like what's going on. Do they have their tablet in there? Like, do we need some screen time guidelines that we discuss together? Oh, personality disorders. Okay, so the DMID2 suggests modifying DSM-5 criteria from age 18 to age 22 because IDD can be a developmental disorder. So the two personality disorders that I want to talk about today are antisocial and borderline. So antisocial, we're running out of time. So let me just tell you, for both of these, we just want the team to be on the same page. So sometimes this means the having everybody meet together so that there isn't like, well, so-and-so told me that I can do this or I can do that, which is also true for borderline personality disorder. Borderline personality disorder, there's a lot of people saying like, there's a lot of mean research. The research isn't mean. There's a lot of stigma associated with borderline personality disorder. I love working with people with borderline personality disorder. There's newer research that shows this isn't as persistent, that people do get better 85% of the time. So just so that you know about that. We don't have time for the case. Thank you so much. So do we have, it looks like we have, oh, we have an OCD. We have an OCD, OCPD, ASD question. So when does OCD become a separate diagnosis as opposed to being a component or symptom of ASD? So usually autism spectrum disorder is pervasive, right? So autism spectrum disorder has started when the person was either born or at age 2, like early on, and it's an early childhood disorder. OCD usually starts at, there's like 2 phases in life, and one is kind of childhood and one is a little bit later in life. So we're looking at a change from baseline. So a person with autism has always been like that. That's less likely to be OCD. And it's more likely to be an exacerbation of autism. So I hope that answered. That was not a great answer, but it's really tricky. Okay, any other questions? Thank you so much. I'm sad we don't have like more time for questions. Okay, we do have 2 minutes though, if you wanted to use the last 2 minutes. Here, I can click back to the other slide. Okay. Yeah, so when we're talking about personality disorders, we just want to make sure that we access the care that's available. So that means any kind of therapy that we can get a hold of, great, love it. Thank you so much, therapists who see our patients. And to remember that medication is not the treatment of choice for borderline personality disorder. Sometimes we need to use it, but that's not the treatment of choice. Oh, thank you. You're all so sweet in the chat over here. And then I think I have the references. Oh, you want me to click to the thank you slide? So I think that's good. I think can we call it?
Yeah, I think so. I just want to let everybody know you will be receiving an email about an hour after the webinar's conclusion that's going to have a link to My Learning, where you can fill out the survey and get your CPDs or CEUs.
Thank you so much for coming today.